It's exciting, and it's actually great on the heels of those questions to be introducing a panel on the next generation of telehealth. So how many of you are working in some capacity in your system with telehealth? A handful. It's in a third of the room, maybe. And interesting, I've been working at CHCF, at the California Healthcare Foundation, on telehealth for probably about 7 or 8 years now. And as all of you, or certainly those of you working in it know, there's just been a sea change. It's a remarkably different environment for telehealth than it was. The needs that are stimulating our use of telehealth, lowering cost of care and improving access to care, are still there and are growing. But the technology platforms, the bandwidth, and just the usability of the technologies for telehealth have changed dramatically since I started. The first telehealth project I did, I remember one of the major costs was actually to pay for extra bandwidth to get a very simple telehealth program out into northern rural California. Now we have subsidized bandwidth and low-cost bandwidth, and now we're really focusing, as Mark was indicating, on some of the issues of provider adoption and of some of the human things that we need to be able to figure out how to do better, the workflow issues, to knit the technologies together with the people in need. So I'm really pleased today we have a very interesting panel, 3 different perspectives from different parts of the world. And I'm going to introduce all 3 of our speakers now, just so we don't have as much shuttling back and forth from the podium. We're going to start out with Dr. Tom Nesbitt, who has a number of different titles. He's the Associate Vice Chancellor for Strategic Technologies and Alliances and the Director of the Center for Health and Technology for the UC Davis Health System. But I think the simplest way to understand what Tom does and understand the role he's played in telehealth is that he directs all of the telehealth work for the entire, he's the thought leader of the telehealth work for the UC system, so for all of the UC medical campuses across the state. He's a national leader in telehealth, serves on all of the major boards, has spent a lot of time thinking about policy reimbursement as well as the workflow challenges in telehealth. And he is also a physician. He's a rural medicine specialist, so really came into this from the perspective of trying to deliver better care to patients in rural areas. Our second speaker will be Rahul Reddy. He's the CEO and president of Apollo Health Resources, a division of the Apollo Group companies. He's also director of the Apollo Innovation Company. And Apollo, which he'll tell you a little bit more about, owns and manages 50 hospitals, as well as clinics, pharmacies, and consultancy services across several continents. I think now India, Africa, and Southeast Asia. So Rahul has a really interesting perspective to offer from work on the ground in the developing world and thinking about how to take technology and healthcare out from these hospitals into the more remote regions. Finally, we'll be hearing from Roger Lee, who's a senior manager with Cisco. He's focusing on corporate social responsibility. After the 2008 earthquake in China, Cisco committed to contribute to major public-private partnership with the Chinese government. And Roger's going to talk about a very specific application on the ground in China using telehealth technologies to reach out to people in remote areas of China. So I'm going to let Tom come up and get us started, and I will be back to take questions when we finish all 3 speakers.
Thank you very much. Really happy to be here. And I'm going to talk about some technologies in different settings, which we'll go through. But first, I want to just sort of set the stage here. You heard a lot about technology in use in different ways. But really what I want to sort of start with is breaking sort of technology and knowledge into 2 basic groups. Or information and knowledge into 2 basic groups. There's information about the patient or a population of patients. That's important information. That's the kind of information we manage with electronic health records, etc. The second kind of information is the science that's out in the world that applies to that patient, the knowledge that applies to that patient. And for quality health care to happen, you really need to bring those 2 kinds of information together at the same place at the same time. And technology can do that. We can use technology to bring that back together. Now, the second kind of information, the knowledge, is really what telemedicine focuses on, but some telemedicine focuses on the first type. But I want to talk a little bit about the history very, very briefly. you know, there is actually a long history of transmitting or sending information over distance. Some of it involved the first kind of information, some the second kind. They used to mark houses with leprosy. They put flags on ships that had plague, and we transferred that. But even after that, there's a history of sending letters to doctors with symptoms and doctors sending back prescriptions. The telegraph and radio was used in the early part of last century for telemedicine. There's some famous stories out of Australia and other places where the telegraph is used. We certainly use the telephone. But really sort of getting into the modern era, back in the 50s, NASA began using remote technologies to get information that they were going to use in the space program. But they tested this in a program called a Space Technology Applied to Rural Papago Advanced Healthcare. They tested this on the Papago Indians. Television came into this in the 60s, where a closed-circuit television system was set up between Norfolk State Hospital in Nebraska and the University of Nebraska for psychiatric care, and then closely followed by Massachusetts General Hospital, linking with Logan Airport and the Bedford VA. And during the time of the 70s and early 80s, there's a number of projects around the world, too numerous to mention. But if you look at the literature, things sort of died down a little bit in the 80s, but then sort of ramped back up at the end of the 80s. And one of the most visible projects was when the Soviet-Armenian earthquake occurred in 1988. The space bridge, which was the satellite ring that's used right now to communicate with the space station, was being put in place. And they used that to link 5 U.S. medical centers to Soviet Armenia. And that was a very successful project. And then the Department of Defense really advanced telemedicine. The U.S. Department of Defense advanced telemedicine for the wars in the Middle East and Kosovo, etc. So that's sort of the history. But what I want to talk now about is sort of these technologies in 3 different settings. The first I want to talk about is in the home and in the community. One of the biggest reasons to have these technologies in the hands of people and in the home is related to chronic disease. Chronic disease is common. It causes a lot of mortality and morbidity. It's a very expensive problem for many countries, including the US. And one of the things that people are realizing is that treating chronic disease the same way we treat acute disease doesn't work. You can't see people episodically every 3 months or every 6 months and hope to control their diabetes or their hypertension. And so technology can bring physiologic data on a real-time basis to help people either self-manage or to help providers manage. Now the VA figured this, the Veterans Administration here in the United States, developed a project over 10 years ago now where they began using these devices in the home where chronic disease management nurses could help patients manage their conditions. And this was very effective in reducing emergency room visits. It was very effective in reducing hospital days and skilled nursing days, and really showed some very beneficial outcomes. And this was relatively simple technology. But where we're moving in this area, I think, is to more sophisticated technologies and body sensor kinds of technologies that are relatively cheap. And this is a picture from that Paul Wright, a cartoon that Paul Wright put together, who's at Berkeley at Citrus, where people have wearable devices that have Bluetooth, and they take physiologic data and send it to a cell phone or send it to a computer, and then that information can alert the patient themselves to do something different, or even send it to their provider. And I'm trying to use a Berkeley example since we're in Berkeley today. This is a device that the Berkeley engineering folks are working on. You can see how small the device is, and it combines a number of things, accelerometers, ECG, stethoscope, and a number of things can store data. And again, the form factor is getting much, much smaller for some of these things. This is from Eric Topol at the West Wireless Institute, showing the millions of Americans, and you can multiply that in other countries, that are affected by these conditions. And these are the potential wireless solutions to address those problems. So you can see there are wireless solutions that are already here that could make a big difference in those areas. Now, telemedicine in the ambulatory setting is really sort of what a lot of people think of as telemedicine. They think of sort of a video-based interactive consultation. And the reason this sort of developed so quickly is that there is a lack of specialists in a lot of parts of the world and certainly in the United States in many areas. And it was a way to bring the expertise of a specialist to where the patient is and allows that expertise to be customized to the patient as opposed to a static source of information like a textbook or something like UpToDate or something like that. And again, this was relatively expensive. There are also some solutions that have been very, very successfll, using store and forward or asynchronous solutions. And this is for teleophthalmology, for retinal exams, non-mydriatic cameras where you're not dilating the eye. You take a picture, send it to an optometrist or an ophthalmologist. And for retinal screening for diabetics, this is critical that you do annually. And there's been some very successful projects, one funded by the California Healthcare Foundation, that have really shown some great value. So this isn't particularly new. This is more than 15 years old. This is in Alaska, in northern Alaska. And the native population in northern Alaska has significant problems with ear disease, and particularly conditions that cause loss of hearing. And this project used a community health worker with a high school education. They trained them how to use these devices and do audiograms and also examine the ear and send the images down to Fairbanks or Anchorage for a specialist to look at and recommend treatment, or in a few cases recommend some of them fly down rather than all of them having to fly down. And this was a very, very successful project. But now we're moving into more, I should say, smaller devices, less expensive devices, and devices that can be spread out into more areas, particularly in low resource areas in other parts of the world. And this is connected to a cell phone where you're getting an image and you can just send that image without having to use the more sophisticated equipment. And this cell scope, which again was developed in this area, it has been used very successfully for looking at microscope slides for malaria and other conditions. Rather than sending a slide to a pathologist that takes weeks to get back, right away you can get an answer. And again, there's some successful projects in Africa where this is used, and a second generation is being field tested right now. So, hospital-based telemedicine. This is a picture of actually one of the projects we're running at UC Davis. This project was also initially funded by the California Healthcare Foundation. But this is a project that now has HRSA funding and is spreading out in California, where we have video conferencing units in small emergency departments in rural areas. And we have 24/7 availability of pediatric critical care physicians that are available for critically ill and injured children. And really, I could tell you many, many stories about the benefits of this. The biggest benefit is so many of these children are not transported that would have been transported had this not been available. And this is even moving to less costly devices. This was a relatively famous case that made it rounds on the internet. This is Dr. Javed Siddiqui, who's an infectious disease doctor. He got a call from Sonoma Valley District Hospital in Sonoma in the wine country for a patient, an obese patient with diabetes that was allergic to 2 different antibiotics. And the doctor said, "What antibiotic should I put this guy on? He has cellulitis." And he said, "You got an iPhone? Why don't you just take a picture of it so I can look at it?" He said, "It's just cellulitis. Let me look at it." He took a picture of it. He said, "That looks concerning to me." And he said, put it in better light, took another picture, and he said, call your surgeon immediately. This guy has necrotizing fasciitis or flesh-eating bacteria. It went around, the headline on the internet was, iPhone saves patient's life. And in fact, that's true, but it shows that these devices can do very well for providing that kind of service. In the inpatient setting, EICU or remote intensive care is something that's grown up very quickly in the United States and has shown significant benefits in decreasing costs and improving quality. And this is being done, as I say, on a wider basis in the United States and beginning to be done in other parts of the world. And sort of the ultimate of this is being able to project not only knowledge, but being able to project technical expertise. There are surgical robots now that we do a lot of procedures with. We do, gallbladders, and we can do prostate surgery and those kinds of things. But these are multi-million-dollar machines. This is a group between UC Santa Cruz, UC Berkeley, and UC Davis that are working on a low-cost, smaller surgical robotic system that can be operated over distance to do certain kinds of surgeries, and they've begun testing this. But this is going to be a very interesting advance to have surgeons being able to operate on a regular basis. They've done some of these over distance with the more expensive machines, and they work quite well. So in summary, I think there are real opportunities for these technologies to make a huge difference in healthcare. I think what we're seeing is the cost of these types of technologies that can be used for telemedicine coming down, and I think we're going to see really an explosion of these technologies across the world for a variety of different conditions, and I think it will be beneficial. We'll talk about the downside during the panel.
Well, I'd like to thank everyone. Certainly appreciate the opportunity to be a part of this event. I definitely found it quite interesting. As Margaret introduced, my name is Rahul Reddy. I represent Apollo Hospitals. I thought I'd start with a little bit of context first. Apollo Hospitals was founded in 1983 in Chennai, India. At the time, it was the first for-profit hospital in India. Also keep in mind at this time, India was still a socialist country, so you did not have for-profit hospitals. Since then, Apollo has grown beyond hospitals, from currently about 54 hospitals. We also have an insurance arm, the largest pharmacy in India, currently about 1,200, should be 1,500 sites by the end of the year. 100 plus clinics, plus a variety of other group companies related to healthcare. So with all these resources, to date we've treated about 20 million people. Last year alone, we did about 5 million preventative health checks. So this is with all the resources, 50 plus hospitals, 100 plus, well, number of clinics have grown, all the pharmacies, 80,000 employees. If you take what we've done, plus all the other healthcare systems, that's still just a dent. You have a population of India of 1.2 billion people. The majority of them don't have access to qualified healthcare. Not only is the Indian market very fragmented, when people do have access to healthcare, chances are they're not qualified. We would know them as quacks. With that, you have several trends that you have to contend with. You do have a growing economy. You have an aspirational population. So there's a growing demand for healthcare. You do have challenges in the sense that India still has limited infrastructure, whether this is roads or telecom or buildings. It still has a way to go. Now on top of that, India also suffers from a shortage of qualified doctors, nurses, clinicians, something faced in a lot of places in the world. So, what do you do about this? So, Apollo will continue to build out more hospital beds, hospitals, hire doctors, nurses, but there is not enough money, there's not enough capital in this world to build enough hospitals to provide the proper health care to 1.2 billion people. So to address this, we have to innovate. I'm talking about Apollo as a health system, but the healthcare industry collectively as well. Innovation, certainly leveraging new technology, but then also looking at new business models, new processes, new ways of doing things. Why do we think this is possible? So I'm going to cite two examples today. So back in February, the government of Rajasthan, they helped organize a health camp in a rural part of Rajasthan. Over 70,000 people showed up. They were expecting a lot, but I don't think anybody expected 70,000. I think this speaks very directly to the demand for healthcare and what people are willing to do to get healthcare. That's obviously a lot of people to treat. So a number of them that were there for primary health checks, but then one of the things Apollo was there for was to provide access to our specialists. These are cardiologists, neurologists, endocrinologists. Obviously, they weren't all in Rajasthan. They were throughout various parts of the system in Chennai, Hyderabad, Delhi. So, and again, I think this also speaks to the problem of the infrastructure problems in India. So this was an example of how telemedicine was used. Typically, these people would not have access to these specialists. So, but in addition to that, by leveraging technology, and by collecting biometric data, it was able to give these specialists in these various locations a better idea of what is going on with that patient. And I think this also speaks to the idea of new business models. So not only the idea that the specialist doesn't have to be physically located with the patient, but then also how you can work with the government, how private entities can work with the government to enable better access to healthcare. The next example I'd like to talk about is a new form factor that Apollo is working with. These are low-cost clinics. Typically, these can be in a form factor of 100 square feet to 500 square feet, very similar to what Dr. Smith referred to as the minute clinics. These are going to be providing primary healthcare services with access to specialists via telemedicine. And then in addition to that, they'll also include regular health camps on a weekly basis where we'll have actual specialists come in to the facility for that particular weekend to advise people on issues related to cardiology. Or next week it might be maternal health. The following week it might be something else. The goal with these clinics is how do we have to provide healthcare services to the underserved or unserved. These are typically people making $100 a month, $200 a month. And to effectively do that, we have to provide a suite of services that they can afford. This typically means a health check for about $1, a primary health check for $1, maybe $2. Specialist consults for obviously a bit more than that. And the only way we're going to be able to make that happen is by leveraging technology. This includes telemedicine, but then also combining that with biometric data, but then doing other things like how do we upskill lower cost personnel? This may be a trained community health worker, it could be a nurse, some form of clinician, but then also back them up with our medical call center. And this is essentially a call center staffed by nurses and doctors that can provide advice to that health worker out in the field. And given that this is meant for the underserved or unserved population, there is very much a very big demand for this. And so it was determined early on this has to be self-sustaining, meaning we have to turn a profit. And again, it comes back to how do we leveraging technology. If we were to do this in the traditional method, it wasn't going to happen. The only way it would happen if somebody was able to subsidize it. But through the use of technology, we're able to lower cost points and make healthcare much more accessible and affordable.
So thank you, Rahul and Margaret. So it's my honor to be with this forum and to have the chance to introduce what we have been doing in Connecting Sichuan in the past 3 years. Actually, as Margaret briefly introduced, after the 2008 earthquake, which has taken away about 70,000 people's life, and Cisco, as a company, we immediately reacted with a major CSR program, corporate social responsibility program in China. We partnered with the Chinese government to launch this Connecting Sichuan program. Basically, Sichuan is the province where the earthquake happened, and Cisco supported the rebuilding of the education and the healthcare sectors with an investment of more than 50 million US dollars. So healthcare-wise, it's a large, the hard-hit area is quite large from, I would say from, which one is it? Here, okay. This is the epicenter, this is the provincial capital. Actually, the earthquake affected area range from, for about 1,000 kilometers in the country. So we don't have the resources to do everywhere, but we just selected some very typical areas in China, in this province to support. One is we call the capital city in Chengdu, which is a metropolitan area with about 10 million people. And another one is Wenchuan, which is where the epicenter is. It's basically a county with about 4,000 square kilometers of land, purely mountainous area. The land, the altitude can easily rise from 600 meters above sea level here to 6,000 here. So in just a few, 20 to 40 kilometers away. So that's where the earthquake happened. Another one is we call Deyang, which is a combination of well-developed plain areas as well as some mountain areas. So China, as you may know, that is a very unbalanced country. And the areas we chose to support is actually a miniature of this country with the well-developed metropolitan areas as well as very underdeveloped rural areas. A little bit about the Chinese healthcare system, delivery system. I think Professor Hu may give a more in-depth introduction on Friday, right? So here I just want to talk about a little bit about the hospitals here. Just like Rahul said, in China we have a lot of challenges. Big country, lack of qualified doctors in the rural areas. But actually we need to think about it. If we further break down the healthcare sectors, we can categorize those organizations in a few categories. Number one is that we call Tier 3 hospitals. Basically, they're major medical centers located in big cities. They actually have all the advanced technologies. Just even some of the hospitals may already have the surgery robotics there, but they are too busy. And people just, came in from all over the country to those, about 1,000 hospitals in the whole country, pack them all day long. So that's one challenge from them. They want to improve the efficiency. The second tier, we got Tier 2 hospitals, mainly will be the community medical center serving the local region, like a county or a small city. These hospitals are much less busy than the Tier 3 one. They have basic technology and kind of qualified stuff. And lower, go to the townships, we have health centers. Those places, basically, just like Rahul talked about India, the doctors there, frankly, if I am in the township, I may not go to there to see the doctor. They can do some basic things, but you don't trust them generally. And the lack of the kind of qualified medical devices as well. And government basically in China controls most of the things. More than 90% of the health organizations in China are government owned. They control the social medical insurance plans. They own the hospitals, and they also actually supervise the compliance of all those health organizations. So when we're doing this program, we actually work with the local government to better understand their needs from different levels. So for the providers, we want to address the efficiency challenges in the big hospitals. We also want to address the lack of skills in the lower tier hospitals. And government-wise, they want to manage the population health. They want to improve the healthcare delivery quality in the whole region. So how can we help them to do that? On the other side, they also want to, to better manage their social medical insurance fund. And patients, for those people living in the high mountains, they actually don't have a lot of choice. They have to go to the township health centers. They don't want to travel for example, 4 hours, 5 hours to a nearby city to get treated. So they don't have any choice. How can we bring the qualified services to them? That's all the challenges we face in China. So what we have been doing there, Cisco basically is an IT company. We produce networking and collaboration technologies for the whole world. So we want to leverage our strengths in this area to support the healthcare side. So we basically, we were not going to build the buildings, or we are not going to donate the medical devices, but instead we built the IT infrastructure for the whole region. So what we did, in number one, we actually supported some of the busiest hospitals in Chengdu, which is the capital city of the province, to help them to make the hospital smarter, to make them, the patient experience in the hospital better, to make the doctors and nurses to collaborate more effectively and to work more efficiently. So this is what we call smart hospital, how we use technology to improve a single hospital, especially in those very busy medical centers. And number two, we built some regional healthcare clouds or networks. So basically the idea is that, since most of the hospitals are government-owned, we built one data center, one network, broadband network in one region, for example, a county, to connect all those health organizations in the region. They can share the applications and data in this data center through the network, and they can also use the network to provide telemedicine services. So this one, thanks to the improvement in Chinese, telecom infrastructure, even in regions I just showed, like Wenchuan in the high mountains, they were able to build a dedicated optical fiber network, which can provide 100 megabps bandwidth to each health organizations. But for the they utilize not the commercial carriers like China Telecom or China Mobile. Instead, they use the local cable TV bureau, so which it's also controlled by the government. They just leverage the fiber at a very low cost. This ensures the sustainability for the bandwidth, and for the data center piece, for a small hospital, like 10 people, 20 people, they actually cannot do anything IT. But in this centralized way, they can provide applications, provide all the services to the whole region collectively. So that's the cloud. We also donated 3 mobile clinics to the region, which can tour around the province. They can be, when they tour to a health center, they just plug in the cable and they can be connected back to the data center or any other health organization in the region. And on top of all these, we did a lot of, interesting trial of telehealth services there. I give you a quick view of this county, which is called Wenchuan, as an example for the network there. Basically, in this mountain area, we have 2 data centers. One is the main data center. The other one is about 60 kilometers away as the disaster recovery data center. And the cable TV network, which basically connects to every township health centers. We do a lot of things. I show some pictures for you. This one shows a picture of a psychological counseling session between a pregnant woman in the mountain area and a doctor in Hong Kong. Before the earthquake, China is not, we didn't do a lot of psychological counseling in China at that time. So we don't have this kind of specialist. The doctors in Hong Kong supported them. Previously, they needed to travel from Hong Kong to Chengdu and then to the mountains. It took the specialists quite a few days for a trip, but nowadays they can just use the teleconferencing piece. And we actually have an investigation to the patients, they believe that this kind of high definition video, high quality conversation is crucial for this psychological counseling. Those ladies, they lost their first baby their only baby, their only child in the earthquake, and they already were like 36 to 40 years old, or even elder. It's not, they're very nervous. China has only a one child policy, so they want to get pregnant again, but the it's not easy for them to keep the child. So the counseling for them is very important. And they believe this high quality video is very important to build the trust between the patient and the specialist, especially when they are speaking two different dialects of the Chinese language. So this trust based on this high quality video is very important. This one is another case between the Wenchuan People's Hospital, which is the Tier 2 hospital, and another Tier 3 hospital in provincial capital. You can see from on both sides, there are doctors. Actually, sometimes they don't bring the patient there. They found that the most effective way to use this in the Chinese situation is that to use this technology to enable the doctor-to-doctor discussion between the senior doctors in the medical center and the junior doctors in the rural areas. This one helped them to review the cases which the junior doctor cannot make the right decision. On the other side, the junior doctor felt it very helpful for them to improve their skills. This is why we say that it's not only about curing a few people, but it also improves the skills of the junior doctors so that they can serve more people better. And they also have some innovative kind of a compensation or incentive plan in this. They charge more, actually, they charge more to those patients, but those patients are very willing to pay more because they can calculate. It actually, in the end, saves them a lot of time and the transportation cost and accommodation cost in the capital city. So that's the one how they use the we call telepresence or teleconferencing infrastructure. Nowadays, we have been integrating this with a lot of medical information, a lot of workflow in our Cisco Health Presence service. But at that time, we only have this simple one. And this is another solution we deployed in one of the regions we supported. It's basically a teleradiology application developed by a Chinese company. It's also it's a regional PACS system. It's a regional imaging system. All the images from the health centers are sent to a data center to be stored centrally. And the way they do this is that for the township health centers, they don't have the digital radiology devices. They only have the film one. They installed a all-in-one device which can scan the films at a relatively high quality and transmit this image to the data center. And the junior doctors and the senior doctors in both ends can review the same image and the diagnosis. In this way, the senior radiologist can ensure that the diagnosis of the junior radiologist is the quality is assured. And in some parts of China beyond this project, we know that there are some regions that they deploy this application too. Their way of using this is that all the images will be sent to a central hospital for diagnosis. No one in the grassroots level hospitals will do any diagnosis. They have some statistics saying that actually in this way they correct it, maybe 40% of the original diagnoses are incorrect. They ensure that actually using this way they just very dramatically improve the quality of the diagnosis. And I think time is up, and I just want to quickly go through the cloud. It may not be the traditional telehealth, but anyway, we built the data center, and our partners built the application, which is basically a centralized deployed application to run all the business in the region, including the pharmacy management, including the EHR, including almost everything for the health centers in the region. But more importantly, China has been undergone a major health reform program in the past few years there are a lot of policy changes. There are a lot of funding going to the health centers by the government. They use the data, collected the data, and do the reporting to the analytics to see how those policies has been, executed in the township health centers. And in this way, they further regulated those health centers to make sure that they are compliant with this new policies. So that's the whole idea of this application. And I may just keep these examples and smart hospital scenarios, which we used all the video, all the new fancy-looking things to improve the patient experience and the doctor's working efficiency. So that's a quick introduction for this. Thank you.
As I reflect on the three speakers and think about our work in California, I think we all agree this telemedicine, telehealth technologies offer us an incredible opportunity to lower cost, improve convenience, and improve quality of care. But I think the questions that come up, and I imagine these will be the categories of your questions and encourage you all to ask them, is really thinking about the challenges of technology, and particularly now for us, integration of these technologies with electronic health records and other technologies in hospitals and clinics, of people, of providers and consumers. How are they responding? Is this fitting into their workflow? Of policy, what kinds of policies are helping or impeding telehealth from being used as efficiently as possible to lower costs and improve access? And then finally, payment. These are all things that we have been challenged with in California as we think about getting telehealth programs out there on the ground to improve access and reduce cost. And we've been working hard in those areas, but I think we have a very interesting analog in the work that Rahul's been doing in India and that we heard about in China. So I'd love to now open it up to questions, and I believe there should be a mic going around the room.
My name is Han Chong. I'm from Singapore. What is the issue with liability? So for example, if you're a physician in Singapore and you're trying to make a diagnosis for somebody in Sichuan or in Bhutan, and you make a mistake, or you misread, or the information coming to you is not adequate, and you don't give the right prescription, the patient dies. So what scenario plays out in that situation?
As I mentioned, in Sichuan, we only deployed the teleconferencing piece. But nowadays, when we really recognize the same issue you are talking about. So in our health presence solution, nowadays, we integrate actually medical devices like the exam cameras or stethoscopes, which are all digitized and FDA certified. And I think another important piece is that besides those real-time diagnosis images and signals, we also need to integrate or at least share the medical records of the patients and some exams beforehand, like the lab results and the images. So this is why the solution not only integrate the workflow, not only integrate the vital signs and the real-time signals, we also integrate with many other applications.
Liability is a huge issue in the United States in healthcare. So I'll say two things about it. One is that in the United States, the belief is that it is the physician traveling virtually rather than the patient traveling virtually. So the belief is that if you provide care into California, you're going to be subject to the rules in California. And in fact, they require licensure in California, but most people believe you're going to be subject to the malpractice rules, et cetera. But in terms of the risk, malpractice risk, which I think you're addressing, if you're a gastroenterologist and you're doing an endoscopy and the prep isn't good enough and you miss something because the prep wasn't good enough, you're liable just like you would be if you didn't get enough information via telemedicine. What we tell our providers is if you don't believe you have enough information, don't make a diagnosis and don't treat. Say, I need more information. I believe it's this, etc. But we tell them to treat it just like they would any live visit where they didn't have adequate information. For the most part, when somebody's looking at a skin lesion and they have a history and they get a very clear look at a skin lesion, they can say, this looks like this or looks like that, you need to get a biopsy. In most cases, our doctors don't feel worried about it, and there have been very, very few malpractice cases. There now have been some, but it's very few compared to the number of telemedicine consultations that have been done.
I mean, at one more point in China, actually, there is no, explicit regulation regarding telehealth. Even the Ministry of Health is doing experiments. They just want to see what's happening. They allow people to try, and they want to see what happens. But the reality is that this is why we say we see doctor to doctor kind of setting. So the senior doctor in the medical centers, they review all the information, but they only make recommendations. It is the responsibility of the local doctor who will make the final decision. Normally they'll follow that, but it's their responsibility to do that.
I wanted to ask this question of how much of an experience there is in applying the technology, in the public sector as opposed to the private sector. Two, how much of it has been used for surveillance, building on passive surveillance systems that may be in place either out of the private or the public sector. And three, to test the partnerships between healthcare providers, educational institutions, and other kinds of stakeholders in this process, because clearly, as I listened to Rahul's presentation, there are multiple opportunities to conduct large-scale camps, and that's a very efficient modality of providing one-time care to a very large population who may not have even had that single opportunity, but to follow that up and to sort of piggyback that on to an existing healthcare surveillance mechanism.
Well, I'll start with this. So to give you a little bit of context, so we've done, with just one hospital out of Chennai, we've done about 5,000 we did about 5,000 teleconsults last year. The majority of them were secondary consults. So it is actually a very good way to stay in touch with patients, especially if they've had to travel from a long distance. In terms of surveillance, we're strictly using this for the relationship between the patient and the clinician for now. So whether that's they come into a clinic or they come into some facility and they want to be seen by a clinician or a doctor that's not physically there. In terms of where it could go with passive surveillance, what we are experimenting with is quite a bit of mobile technology. And so the idea is to get, as prices come down, cameras, cell phones, cost of telecom, you name it, we do see this becoming much more ubiquitous. So we see a great opportunity for it to proliferate out into different uses, different morbidities, different ways of treatment. But like any technology, it certainly can do a great deal of good, but it can be abused. So the challenge is certainly going to be in how do you protect against, how do you make sure it's used properly to improve outcomes and not abused?
I think there's an opportunity, particularly with electronic health records, once there is enough of the population are using them to do syndromic surveillance and those kinds of things. I think there's some very interesting work that could be done, to predict things like influenza outbreaks and things prior to, just based on increases in number of visits, et cetera. So I think there's opportunities there. I also think there's opportunities in public health. There's a project called the Dengue Torpedo Project, which is, some of you may have heard about, where it's for dengue, and there's been some work done in Brazil where people are looking at high-risk areas for dengue with, standing water and those kinds of things, and there's a relationship with the public health where if they identify things, they get extra text minutes and those kinds of things. So it's a way to use the ubiquitous cell phones to build a public health workforce essentially out of citizens with very low cost kinds of applications.
This is not a question per se, but I just want to share some of my telemedicine experience that we are doing in India, especially in the rural healthcare in the northern part of India. We have used a very low-cost telemedicine solution which has some diagnostic equipments with a web camera and other things, and put it up in villages which can work in a very low bandwidth solutions. And using the existing doctors, we agree that there are no qualified doctors per se. There's a lack of around 6 lakh doctors, but there are medical service providers across India. So we used them, kind of accredited them, and said that, okay, this is what you can do, this is what you cannot do, and then have them connect up to the doctors in Delhi. And we charge about $1 per consultation, which includes a certain generic medicines also. And it has been widely successful across around 1,000 villages, and we have seen around 20 million people till now. So there are some challenges, as I expressed earlier, in terms of the doctors accepting it. We had to do a lot of referrals. Providers kind of not very keen on seeing the patients there, but surely it has been successful amongst the villagers at least.
Telemedicine's been around for about 20 years. About 20 years ago, the technology supporting telemedicine was pretty poor, and there were some very good reasons for not using it. But over the last decade, the technology supporting telemedicine has been fantastic. I think it's interesting to reflect on the fact that most examples given of the use of telemedicine tend to be in rural and remote locations. And there it's fantastic. It is the difference between life and death. It truly is. And in the bush, there's a necessity to innovate. Otherwise, things just don't get done. And we've heard some very good examples of that. But one of the key innovations that occurs in rural and remote areas is that people step outside of their traditional roles. It amazes me that we as a system have not made more use of telemedicine in the metropolitan areas. And again, the primary reason for that is because we're still locked into a paradigm where the dominant feature of that paradigm is that the clinician either insists on or is rewarded in seeing the patient physically. So we don't have a technological problem. The technology is there and it is absolutely wonderful. The medical indemnification issue is a relevant issue but manageable. And we've certainly had no difficulty in managing medical indemnification through consultations done remotely. And the rewards, the clinical rewards in doing remote consultation via telemedicine have been fantastic. I think one of the key challenges for us is to change the paradigm of care and make use of a technology that is absolutely fantastic for metro locations as well as bush.
The clinics I referred to that were getting up and running. So we have our traditional telemedicine clinics. These tend to be out in rural areas, but these low-cost clinics where we use telemedicine to do secondary consults, but we also use them to upskill personnel to get the cost of a consult down. The majority of them are in metro areas. In fact, I don't know if it came too clearly across on that PowerPoint, but there's a picture about where one of them is, and it's actually located just outside a lower income place. So we definitely see a great opportunity for it within metros. I think one of the challenges, at least here in the U.S., with getting it used, whether it's rural or in an urban area, has been the reimbursement. You know, once you get that figured out, everybody sees the benefit for it. Outside of the U.S., depending on where you are, you have a little bit more leeway to try some things out. But what you have to make sure is, does it resonate with the paying customer? So again, it comes down to reimbursement in a sense. It's just in once. Here, it's the government. There, it's the private individual. So as long as you can, show that you're delivering value and results, it can happen. We're using it in metro areas, but I think, to speak to your point more directly, I think you will start to see it used more pervasively in metro areas beyond just rural applications.
Yeah, and I'll say that a lot of the clinics that in the project that Margaret spoke about with this specialty care safety net initiative that we did with the 5 UC campuses. Many of those clinics were in urban areas, but one of the challenges, as you mentioned, is that for some payers, like Medicare, the originating site has to be in a rural area, and even how they define rural is kind of screwy, because there's some fairly rural counties that don't get counted. So you're absolutely right. I mean, it really is a paradigm shift, and I think the other big challenge is the organized medicine is really concerned about scope of practice issues, and having, you know, what we're talking about now, to sound politically correct in some of those circles, are to talk about at least allowing people to practice at the top of their practice of their license. So practice at the top of their license, but people are very worried about, you know, if you let a dental hygienist take x-rays on their own connected to a dentist via teledentistry, what does that do to, you know, their income? So I think it really is an issue, but you're absolutely right. There's huge needs in urban areas, and we're not taking advantage of it to the degree we could.
I may share some new development in China nowadays, which we happen to know. One example is, you know, about home care. Some Chinese companies are now starting doing this. I know there's a long way to go, but I think some new business model is now being tried in China. Number 2, I want to share another story with the leading hospital in China's Xinjiang, provincial level. The hospital there, they actually have a call center for all those discharged inpatient patients. This call center can provide a paid service for those patients for like 3 months, for example. They'll call you periodically based on the doctor's orders before you discharge. And this fee can be, you know, they are discussing to include this into the social medical insurance plan so that they can be reimbursed. In this way, the government, you know, the insurance just pay a little more money, and the readmission will be significantly reduced. So that's some new developments in China.
Thank you. Well, please join me in thanking the panel, and I believe we then move to break, so we'll have time to chat a little more. Thanks.